Jeremy Warner from Vanderbilt, who's primarily appointed in hematology-oncology, which means he's a cancer doctor, and secondarily in biomedical informatics. So Dr. Warner is an assistant professor of medicine and biomedical informatics at Vanderbilt. He did his bi-postal education, as best I can describe it. He started out academic life at MIT, which I think is a small school in Boston, right?
Cambridge.
Cambridge.
Close.
Some of you may have heard of him. He had a master's in electrical and computer engineering at UCSD, University of California, San Diego, which is on the opposite coast. I know that's in San Diego because that's well the name. Right. No, everybody's heard of that. Then medical school at Boston University, back to the East Coast, and then internship and residency on the West Coast. So literally.
Yeah, literally. Yeah.
At UCSF, a small school in San Francisco. And then a fellowship in hematology-oncology on the opposite coast at Beth Israel. He joined the Vanderbilt faculty in August 2012. His clinical focus is lymphoid diseases, and the reason he's my boss is because he's current chair of the American Society of Clinical Oncology, which is the big oncology society, health informatics working group, which I'm a member of and he's chair of. So, boss.
Thank you. Okay. All right. Well, thank you for inviting me here, and thank you, Wah, for also inviting me here. So, what I'm going to talk to you about is some exciting work that I've been doing through ASCO and also sort of on my own about standards and how we can use standards to improve the care of oncology patients. Just with a show of hands, how many of you are clinicians? Small minority. How many of you work on cancer-related research in any way, shape, or form? All right, great. So hopefully this will be pretty relevant, even if you're not clinicians, because cancer impacts so many of us. Even at a personal level, we can think about it from that angle. So I do have a few disclosures. As Elmer said, I'm the chair of the ASCO Health IT Work Group. I'm a member of the HL7 Clinical Genomics Work Group and the section editor of Malignant Hematology for hemonc.org, which I'll mention later in the talk. No financial conflicts of interest, and a few slides that are not my own are disclosed as such. So whenever people talk about standards, I think they should always show this slide first. So this is a XKCD cartoon, which you may have seen before. And you know what? It's kind of true sometimes. So whenever we're kind of creating new standards, we always have to think about, are we creating a situation which makes things worse, not better? But anyway, I think that this is an example of bad standards. So does anybody see what's wrong with this picture? Exactly. So this is this is a narrow gauge rail track, and this is a standard gauge rail track. And obviously, a train built for one is not going to work on the other. So you end up with double the amount of infrastructure. You fill your city with ugly train tracks. And I think the only circumstance where this is good is if you're Thomas the Train. You can't really tell, but I think this train's on a narrow gauge track, and here's Thomas on the standard gauge track to the rescue. My daughter's only 1, so I haven't yet experienced the joy of Thomas, but I'm sure I will soon. So this is sort of my concept of what's made like a better standard, perhaps. So this is a real place. There's water down there. So this is actually a series of 16 locks to get from down there to up there. And I don't want to carry the analogy too far, but everybody's in the same place, right? Everybody's in the water. The height is standardized. You're going to get from one place to another. It might be difficult. It might take a while, but you will be able to get through. So with that, I like to talk about a clinical case. Common case is a woman who is diagnosed with early stage breast cancer. So this woman, and this is standard treatment, is going to require surgery, chemotherapy, radiation, and then hormonal therapy for months and years. And she has already a primary care doctor locally, but she lives 50 miles away from the nearest center of excellence for breast surgery, and she wants to get her treatment there. She lives 25 miles away from the nearest place to get chemotherapy, and good news is the radiation center is a little closer, 15 miles away. And of course, None of her providers share an interoperable electronic health record. It's pretty easy, actually, to just throw this on a map. So this is where I live, Nashville, and I think this is about 50, 70 miles or so. So, this is hypothetical, but we are the center of excellence for surgery. There is a medical oncologist there, radiation oncologist there. And then I want to emphasize, too, that caregivers really matter, right? So in cancer care, you need a support network, and those people might be visiting nurses or family, and they can be scattered all over the place. So there's Mr. Rogers. So, there is this idea called the patient-centered medical neighborhood, which is a great idea, but I don't really see how it's going to apply to such a wide geographic area. So, so what happens? This happens. So people are communicating with each other, right? But it's haphazard, it's incomplete, and a lot of this communication is out of sync. So what can happen as a result? Medical errors happen. I mean, this is one of the prime drivers of medical error due to lack of information. People end up repeating a lot of tests that cost the healthcare system a lot of money. You can also get into the false positive, false negative issues and conflicts of results. There's a lot of time that's wasted. This is a big one. There's no longitudinal lifelong health record, right? And sort of a central tenet of health informatics is let's find out a way to create for every patient a longitudinal lifelong health record. And that's not good for patient care, and it's not good for secondary use and other types of research. This is one that I didn't think about much because I'm fortunately not a cancer patient, but I've spoken to survivors, and they really can't stand having to tell their story over and over, and basically they see a new doctor who has no information and they have to repeat everything, and it's actually traumatic at some point. And then furthermore, a lot of patients assume that we all are communicating, and we're actually not, and that can also lead to problems. So this, to me, is like a view from the outside, because when I think of the I'm sort of like National Academy of Medicine, used to be called the IOM. But this is have any of you heard of these grand challenges for engineering? A few of you have. So, I think these are targeted at high schoolers or people earlier in their career, kind of laying out like what are these big ideas that we all have to be working on. And one of them is advanced health informatics. I mean, that is one of their among like 10 or so grand challenges. And here's just some wording from that, and I just emphasize that they're pointing out a need for systems to seamlessly share data. That's a big shortcoming right now. And as we get more and more complex, we all need just-in-time, just-for-me advice. So that's actually the basis of my talk here. So I'm going to talk about two big examples under each of these categories of what we've been doing. So as far as seamless sharing of data, I'm going to talk about our cancer treatment planning and summarization work with ASCO. And then just-in-time, just-for-me advice, I'm going to talk about what we've done at Vanderbilt with cancer molecular profiling. So this is kind of the view from the inside, if you will. So this is a nice kind of way to break down how information technology works in the cancer space. And these authors have broken it into different relationships, so say between providers, between a provider and a patient. And what we're trying to do with the work that I'm about to describe is hit a lot of these areas, or hit at least one point in each of these areas. So as a little bit of background, starting 2 years ago, and we've had two of these, ASCO started having an oncology data standards summit. And we invited basically everybody that we could think of in the cancer space, from the government to NGOs to forward-thinking schools like Harvard Medical School to some survivorship organizations, and about 20-plus organizations got together, put our heads together, and talked about standards for a couple days each year. And so, this was as laid out ASCO's goals and objectives. So, really the idea is let's expand health IT standards to meet the needs of oncology and cancer patients. Let's increase the amount of electronically available content. Let's improve the delivery of that content. We'll improve communication, and really to create a foundation that can be expanded over time. And at the time that this was first conceived, this was before the meaningful use stage 3 rules came out. So, we really wanted to kind of get oncology on the radar of the ONC, and maybe they would include something specific for oncology in the newest stage rules. So again, this kind of just reiterates, like I've already discussed, we really need to be able to exchange clinical information. And this has to be really agnostic to an EHR vendor or specific application. And what we're talking about really is semantic interoperability. So, there's got to be meaning conveyed in what you're sending from here to there. So this was the initial vision, and we don't need to concentrate on the text of this slide, but basically our foundation was something called the Breast Cancer Adjuvant Treatment Plan and Summary. That's what we chose to work on first, and I'll explain why in a second. And we also settled on HL7, and specifically clinical document architecture, as our standard of choice. And this is why. So first of all, we worked with Lantana, and anybody who knows Lantana, I mean, they sort of, the folks that make up that organization are foundational at HL7 and have really pushed a lot of standards, including CCDA. So what we wanted to do is develop oncology-specific CDA templates that would extend and be very conformant to the consolidated CDA, which is cited in meaningful use stage 2 and stage 3 now. We wanted to reuse what was out there already. Again, we didn't want to create a new standard if there was something pretty good already there. For those of you who are not familiar with CDA, this is just sort of the overview of how it works. So basically CDA is a collection of templates, and depending on how you put them together, you get a specific document format. So one that a lot of people know is the continuity of care document, CCD. That basically is an assemblage of those specific templates. But you can pick and choose, and you can build new templates as needed to create your standard. So this was our idea. Let's take that tangled web, let's untangle it and put the CDA standard in the center. The idea being complete and replicable communication, and with or without a central source of truth, such as a health information exchange, which helps, but is not needed. So this was ASCO's inspiration. It's on a lot of people's minds, I think, recently. It's the 10th anniversary. I didn't realize the magnitude of this. I was just out of medical school, just started internship, but literally tens of thousands of patients had their records obliterated because they were paper. They were in the basement. I think this is one of the hospitals in New Orleans that just totally destroyed. And a number of those patients were on chemotherapy, and it actually became evident that they had no idea what drugs they were getting. They had no idea how many cycles they'd gotten. Their doctors couldn't remember. Literally nobody knew what was going on, and this really impacted cancer patients. And so ASCO basically came up with this idea, not radical idea, but the idea that let's enable continuity of care even when medical records are lost. And at that time, so this is 10 years ago, the solution was a paper-based template because, as you may know, very few practices, maybe 10% of practices nationally, were actually electronic. But the idea being that this would be a document that is created during the workup and treatment of the cancer, and then handed to the patient, so at least the patient had a copy, the physician had a copy, or the multiple physicians involved. There were templates designed for breast, colon, lung, and lymphoma, which are 4 of the 5 most common cancers. And so, again, we targeted curable breast cancer, which is, as I just described, common but fairly complex. So this is an example of what the paper-based form, which you can fill out in Word or Excel, but it's still, at the end, paper-based when we started, looks like, and it goes on and on. So, when we analyzed this, we found that there were more than 80 distinct data elements on this form. And, they ran the gamut from numeric elements, dated. Some of these elements were clearly going to be encodable to some sort of terminology. And then some of them would be mappable to an HL7 RIM class. And then there were elements that were just clearly best left as narrative. So after analyzing and dissecting this, we created our what we variably call COTPS and or eCOTPS. Not sure which name will catch on yet. So this is you're free to download it. It's 450-page implementation guide, but I'll try to summarize it here. Actually, version 2 is, I think, over 800 pages. So this is basically, again, we used existing templates when we could. So like allergies are allergies. So we used the section that was already there. But then sometimes we had to create a brand new template. So anthracyclines, which are a type of chemotherapy that can cause heart damage long term. It's important to know the lifetime dose that a patient has received. So no such template existed, so we created that. So here just quickly is an example of a new template. We want to describe the estrogen receptor status of breast cancer. If you put this in a narrative document, an oncologist will know what that means, ER positive, but obviously a computer doesn't know what that means, and I'm not going to read the fine print, but that's actually what it means. Nobody wants to type that out in a narrative format. So how do we represent that? So the way these implementation guides, have any of you dug through a CDA implementation guide ever? Yeah, I mean, they're not the most fun to read, but at least there's hyperlinks and you can jump around. So this is an example of the new template and what it might look like. It's all numerically coded. And this actually lives in what's called an organizer. In this case, we actually developed 3 new templates for the estrogen receptor, the progesterone receptor, and the HER2, which are the most common biomarkers that you need to know about for breast cancer right now. And so this is kind of what it looks like as you start to describe the constraints on how you're going to describe this. And then here's an example of the XML that would come out of that if you were following the directions. And that's a key. I got to follow the directions. So you got to use the right code system and so on and so forth. And if you put this in, you should have a semantically interoperable ER positive. Okay, so that's what it looks like. So now I'm going to talk about some implementations. Does anybody have any quick questions at this point before I get into that? All right. Let me talk about what we've done so far. So our first implementation of this was at HIMSS at something called the Health Story Project, which has been actually going on since 2006, and a pretty interesting group, basically a coalition that got together and created, at the end of the day, CCDA with some other colleagues. And what they do at HIMSS is they have a demonstration where they get multiple vendors together, and they are pretty strict. They actually, you have to rehearse at an IHE Connectathon beforehand. You have to pass the test before you're permitted to actually go to HIMSS and do this. So it's pretty stringent. So this was the one that we were involved with in 2014. So each gray circle here would be a different stage in this hypothetical patient's treatment journey. And this is not exactly like the case I presented in the beginning, but essentially this is a case of a breast cancer patient going through her treatment. And in this case, we did have a health information exchange in the middle. And where our document came in was really at the period of time when the tumor board is meeting to talk about what's been done so far in terms of surgery and what's going to be recommended in terms of further treatment like chemotherapy and so forth. This was a fairly big group. There is a video of this, but it probably doesn't play too well because basically the way this worked is there were these 3 screens and each vendor would kind of show their thing on a screen and it would jump back and forth, and it was probably better live than recorded, but this went off well. So about 800, we counted about 800 people actually came by and saw that demonstration. So this was our second implementation. This was actually with a group in California called Inspire, which stands, you can read what it stands for. And basically their goal is to improve the acquisition and exchange of patient data in high impact conditions such as cancer. And they work closely with something called the Athena Breast Health Network. And this is just a quick slide to describe that. So this is essentially all the UCs in California with several Midwest hospitals. And they actually see about half of all breast cancer cases in California, so pretty large network. And all of their providers, to join this network, you have to be using an EHR. So this is what the Athena Inspired project did. So if you look at actually the bottom, this is what they ended up doing. They basically set up a system where they would have a cloud-based web app that used Salesforce. This is not the new Salesforce Health Cloud, but this is like a predecessor to that. And they would basically, I think inside the Epic desktop client, so basically in the workflow, enable the creation and completion of this treatment plan and summary. And then that would actually move on to a health information home where a patient could access it remotely and electronically. And the future goal that they had was to basically use the CDA to communicate between EHRs, to actually communicate to directly to the state central cancer registry, potentially bypassing a hospital registry, and also the patient's health information home. And then to also use a different standard called the CAP electronic checklist XML to capture other information that they needed above and beyond what the ASCO form had to offer. This is our third implementation, so this just happened about 2 or 3 months ago in early June. So we at ASCO liked the idea of what HIMSS was doing so much that we thought, let's do it at ASCO. Let's actually show this demo type of thing to practicing doctors so they can see what's really going on here. Because if any of you have been to HIMSS, it's great, it's interesting, but there's not a whole lot of practicing doctors, and there's definitely not a whole lot of practicing oncologists that regularly attend HIMSS. So this was our demo that we created. Basically, at this point, we'd created a second revision to this CDA and added colon cancer as the second cancer onto here. And so we used a colon cancer case that basically showed that we can move from this current approach, which is mostly on paper, and to a new approach, which was digital. So this we did video, and I think these slides will be provided, right? And I don't know if those links will be active, but you can type it in. I do recommend watching that video.
We don't provide the slides, we can video your presentation.
Right. So I can share the slides or links or whatever. So I have several links in here, and this is one. I mean, this video is about 30 minutes long, so I can't show it unless you just want me to shut up. But it's a good video. We basically went through the entire demonstration, which was about 35 minutes, and involved these 12 or so vendors. And I don't have the case flow sheet to show you here, but basically, again, it was a colon cancer patient going through family history screening, genetic counseling, treatment, pathologic analysis, including molecular profiling, and then also, importantly, reporting to a registry, and the CDC was involved in this demonstration as well. And that's the big crowd from that demo. So I'm going to just summarize this. So we're very specific here. We're the first oncology-specific CDA standard, perhaps not the first oncology-specific standard, but certainly the first CDA standard to achieve HL7 DSTU status. We're currently actually working on DSTU 2.1, which is involving generic survivorship care planning. So now we're trying to move to all cancers, not just those two that we've done so far. And you can download this now. I think it's been free since fall last year for non-HL7 members. You can just go on their website, download the 800-page implementation guide, and go to work. It'd be great. All right, so I'm going to move into part 2 here. So let me talk about another case here. So now we have similar age woman, but now she's presenting not breast cancer, but metastatic stage 4 lung cancer. And at Vanderbilt and MD Anderson, I know, and many places now, it is standard of care to do some tumor genotype testing in this scenario. And let's say that this patient came back with a KRAS G12C mutation. So what are some of the things that the patient and her doctor might want to know at this point? Well, she might want to know more, what is this KRAS gene? What does that mean? What does that specific mutation mean in lung cancer? How are patients like me going to be treated? How do stage 4 lung cancer patients do, and how do KRAS mutated stage 4 lung cancer patients do? And these are questions that we didn't feel could really be easily addressed actually at this point in time by most oncologists, except perhaps the super specialists in KRAS mutated lung cancer. And there are such people, but they're few and far between. I will just say as an aside, about 80% of cancer patients in this country are treated by community oncologists who treat all kinds of cancer across the board. So what are we talking about here? So as we all know, the cost of sequencing has dropped dramatically, although it seems to have plateaued. This year's data was just recently updated. Might even be getting more expensive, I can't tell, but still very, very inexpensive at this point. And we also have a rising prevalence of genetically influenced treatments in cancer specifically. Starting all the way back in 1954, we had the first, which is warfarin, although we didn't know at that time that it was going to be genetically influenced. That was actually before DNA was described, or the structure of DNA. And then this is a year or two out of date, but this is an example of a recent lung cancer drug that actually the FDA label includes that you must do a genetic test for a certain mutation, a companion diagnostic before you can give that drug. And I believe this line is still shooting up over the last couple of years. And then you've got this, right? So you all are familiar with MD Anderson, who are doing their own molecular profiles clinically and for research purposes in-house, but that's not the case for many places. And these are just some of the companies out there that are in this space. And I'm sure I just updated all these logos like 3 months ago, and probably half of them are out of date by now. People really like to change their logos a lot. And there's probably more players in this space. But you know, it's a lot of different companies here. And they're offering, you know, some of these are very specific, you know, one gene mutation tests, but some of these are offering huge cancer gene panels of up to 500 genes or more. And interpreting those is incredibly complex. So, cancer molecular profiles, I think we're still settling on what the best name for these tests, but you know, these type of tests are playing an increasing role in cancer care in terms of prognosis, predicting treatment effects, helping to choose treatment, and helping to screen for clinical trials. But this is the kind of information that at this day and age is more often than not faxed back from an outside lab. Again, if you don't have the convenience of it, well, I would say some places that do have home, you know, labs built into their institutions still are getting faxes and suboptimal data transfers. So, as you're all surely aware, President Obama announced this precision medicine initiative, and the words right after that were, you know, cancer. So I have to include the whole quote here. And again, you know, the New England Journal article said that, you know, oncology is the clear choice for enhancing precision medicine. So just a few. So this is just one. I could show you many slides like this. This is just an example of how prognosis can be influenced by genetic status. This is a paper about colon cancer, and basically the bottom right here shows that if you have a BRAF mutation, you do much worse, statistically significantly worse than the patients who have BRAF wild type or unmutated colon cancer. But not all mutations are the same, right? So this is just an example from a site called My Cancer Genome, which is out of Vanderbilt, that this gene is EGFR, and different mutations confer either sensitivity to the drugs for this condition called tyrosine kinase inhibitors, and other mutations confer resistance. So, and these are just the common sort of hotspot results. We don't even know, you know, once we get into next generation sequencing, we don't know what to do with half of the results we get or more. However, this is data from Vanderbilt clinicians are clearly making genotype-driven decisions. So the top table here is not surprising, to me at least, that if you are EGFR mutated, you're much, much more likely to get this drug erlotinib, which is one of those TKIs, with an odds ratio of 23 as compared to EGFR wild type. But this was a little surprising to me. You're actually also less likely to get the conventional chemotherapy, and that's potentially good for the patient, right? I mean, less toxicity probably, and a more efficacious drug. So that's what we're seeing, and I'm sure that you're seeing the same thing at MD Anderson for this and other drugs. And again, this would be patients with advanced stage lung cancer, being more likely to get the targeted therapy and less likely to get the conventional therapy. And then this is just data from our recent CCSG renewal that shows for 3 diseases in a phase 1 that we're, for clinical trials, we're using genotype-driven inclusion criteria more and more often. So targeted therapy, that's different, right? So just because a drug is targeted doesn't mean that the patient has to have a certain mutation to get on the trial. So, for example, melanoma, 100% of the trials, or 100% of patients at Vanderbilt enrolled on a targeted therapy trial, but about half of those were included because they met a certain genetic criteria, and then the numbers go down, but they're still there, and these numbers are growing year by year.
I'm sorry, am I understanding this correctly, that 100% of melanoma patients were enrolled in a trial of targeted therapy?
Patients who went on a trial. 100% of patients who went on a trial.
Were given targeted therapy?
Yes. We don't have 100% trial enrollment.
No.
That'd be good. Yeah.
That's why I asked.
Yep. Okay, so we took all this and came up with this idea called Smart Precision Cancer Medicine. And we called it Precision Cancer Medicine before the Precision Medicine Initiative came out, but fortuitous naming, I guess. So what we wanted to do was present this information to clinicians as a component of their practice, but not necessarily in the EHR. Right? And the way we wanted to do that was use an open source application based on the Smart on Fire Genomics API, and I will describe that for you. And then we also wanted to show that with such an app, you could easily link to other knowledge bases to help your clinical care. And this is inspired by basically our operational reporting purposes at Vanderbilt. So we have been doing hotspot genetic testing for a long time. So we have a fair number of specimens accrued in patients. And these were pie charts showing the breakdown by disease. But remember, there's a patient in the middle of each of these mutations, right? So we really wanted to move from this kind of overview population level to an individual patient to place things in context. So this is an overview. So you've got an app here in the middle. You've got some kind of display in context of an individual patient, and then you've got ways to link out to external knowledge bases. How many people are familiar with SMART? Okay. Should be higher, but we'll get there. So SMART was one of the SHARP programs of the ONC, and stands for substitutable medical apps and reusable technologies. And this is really Ken Mandel and Zach Kahan's brainchild. The idea being, if we can do it in our, consumer lives, if we can take our phone and get an app because we don't like the built-in calendar app, we can get rid of that and get the app that we want for our calendar. Why can't we do that in our electronic health records? So, electronic health records are basically the full package, and it's very hard if you don't like a certain way that data is displayed. Tough, right? You either got to accommodate or tough. So the idea is that you create this kind of app environment, and you create this app store, which can be limited by your institution, but at some point you can choose to bring in a new app. So this was their example in the paper they published. This is like the simplest app probably. So it's just checking for whether you're taking a certain drug. This is Java, I believe. This is the full app. Yep, that's it. So I'm just gonna see what happens here. Okay. Probably it's not wanting me to open the link. Okay. So I recommend you go check this out. So this is probably pushing 30 or 40 apps at this point. Most of them are for demonstration purposes, but they cover the gamut from new ways to do growth curves. That's maybe the most well-known, to very pretty ways to display cholesterol or blood pressure, or ways to reconcile medications. They really cover the gamut. And what really pushed, I think, SMART into more of the success levels was the adoption of FIRE, which really happened late in the project. So SMART was a 5-year grant from ONC, and they really picked up FIRE, I think, in the last year and a half. So let me talk about FIRE for a second here, borrowing some slides from HL7. So FIRE, basically HL7 recognized that V2, or version 2, which is still used by most labs today, is really old, over 25 years. And it meets its limited purposes, but was not meeting all the purposes that interoperability demands. It's also V2 slow. CDA is slower to implement, right? I just described the 800-page implementation guide. So what HL7 did is internally they said, let's just take a completely fresh look. Let's just think about healthcare exchange, from scratch, and look at some of the modern approaches. And when they said modern, it's not necessarily like brand new, right? I mean, this is what they found is RESTful-based APIs, which I think have been around for a long time, but still relatively new compared to V2 and some of the other standards. And so basically based on this fresh look, they drafted a new Exchange API based on this approach. This is the Manifesto of Fire. I think this has remained the same since the inception. They wanted to focus on implementers first and foremost. They wanted to accommodate common scenarios. They call it the 80-20 rule. They wanted to use new web technologies. Like CDA and not like V2, they wanted to require human readability as a very important advance. They also wanted to make this freely available. That had been a problem with previous incarnations of HL7. There was a lot of intellectual property that was problematic. They also wanted to support multiple architectures and then have best practice governance. So resources, so FIRE stands for Fast Healthcare Interoperability Resources. So resources are the core to FIRE, and resources are made up of 3 parts. There's a base of defined structured data, there are extensions on the resource, and then there's the narrative human readable portion. So this is just an example of a resource that's providing some basic demographic information. Okay, so putting SMART and FIRE together, you have SMART on FIRE, and there's all kinds of this on FIRE, that on FIRE. There's a lot of good puns around FIRE. But so these were the principles that were laid out for SMART on FIRE. So there'd be a data access layer based on FIRE, which was really meant to meet meaningful use requirements first and foremost. Then there'd be a security layer that uses a modern authentication tool called OAuth 2.0. And then also these apps would support a single sign-on layer with this thing called OpenID Connect, so that a user could sign on to an app inside their electronic health record or parallel to it, but using their standard single sign-on. If any of you were at AMIA last year, this is what the room looked like when they did the FIRE demo. This was sort of the most packed I've ever seen an AMIA conference room. I think probably this year they'll put them in the ballroom, and we'll see if it's still packed. But this was getting a lot of attention. So this is Smart on Fire Genomics. It's basically literally extending the idea further to address genomics and how we bring genomics into Fire. while simultaneously acknowledging that you might be getting your genomic data from multiple places. You might be getting it from your EHR, but you could very well have a sequencing lab here, a sequencing lab there, and you need to integrate that information, and that's the idea behind the Smart Clinical Genomics apps. All right, so back to Smart Precision Cancer Medicine. So we developed this as an iOS app. We based everything on the Fire DSTU R2 ballot version. And we sourced our data out of the Vanderbilt research derivative, and we transformed that into Fire JSON format. I'll show you a little snippet of that, and stored that on a local server. And we define, and I'll show you in a second how we defined the genomic data. So this is just how it looks. It's any kind of sign-on to a Vanderbilt system looks like this, standard. We used our internal single sign-on authentication, but the idea is the same. When you sign in, you get the splash screen, and it's very simple. Just enter a medical record number, and then this is what you would get. So this is an example of a patient that did not have any mutation detected, and I should back up and say that and I'll get to this at the very end, this data is all based on our internal snapshot panel, which is relatively small, between 5 and 8 genes per disease type, and between 50 and 100 specific mutations that we're looking for, so relatively small. So this is AML, and in this case, no gene mutation was detected, so all you see is this one pie chart. If there is a gene mutation detected, so this is the KRAS G12C example that I introduced for the lung cancer patient. Now you see on the left that the KRAS is mutated, and on the right you see the actual change that was observed. And so you can see here, I think at a glance, that besides not detected, KRAS is the most common mutation seen in lung cancer in our population, and G12C is the most common variant. So let's say you want to see quantitative data, so all you do is touch the pie and you get taken to here. So now you can actually see patient counts, and you can see, okay, there's 284 patients, like me, sort of. And from here, you might want to, again, touch that, and you get taken to GeneWiki. Why did we choose GeneWiki? I don't know. Some people think it's good. I actually think it's a pretty good resource, and has a lot of links to more detailed gene information. Okay, let's say you want to know more about, again, that variant in lung cancer. So here, now you can see the numerator. It's a little hard to project here, but you see 142 patients are like this patient, right? So patients like me, that's a fair number, even at a single institution. What happens if you touch that? You get taken to My Cancer Genome. So My Cancer Genome, for those of you who are not aware of it, like I mentioned, is a resource that was initially developed at Vanderbilt, and is now licensed under Genome Oncology, and has basically expert curated data at the variant disease level. So this is very specific, and it takes you to the page that's relevant. If you pressed one of these, you get taken to that page. Okay. So it's also easy to add on to the app. So after we went through our initial round of development, we decided, hey, it'd be cool to, after getting some feedback from users, a lot of users wanted treatment, some kind of link to a treatment database, because that's what they care about at the end of the day, is what are we going to treat this patient with. And so we added a treatment module. So again, here you can touch that, and you get taken to hemonc.org. And here, again, the app knows that you want to know about non-small cell lung cancer treatment, and it knows that based on the ICD-9 code that was underneath. And so it takes you to that relevant page, and you can look through your 42 different regimens and decide what you want to do. Or you can touch the gene icon, and in this case, I'm showing you the BRAF inhibitors page because there are no KRAS inhibitors that are clinically available. So I'm just showing you an example that if that gene had been BRAF, you would have been taken to this page with BRAF inhibitors, and there are 5 clinically available, so you can get to those and start making your decisions about what you want to do. All right, so behind the scenes, we had to make a lot of decisions, and those decisions primarily revolved around what terminologies are we going to use to link this all up. And I'm sure this list is not complete, but this is what we were confronted with. These are the various terminologies for diseases. Here I'm showing the example of melanoma. So what we decided to go with the NCI thesaurus because it's well known. You know, no other good reason for that. I mean, perhaps we could have used any of these. Genes, you've got a lot of different terminologies. Some of these are related to the sequence of the gene. Some of them are related to the name of the gene. And all of these things are changing, actually. I mean, the gene names change all the time. I mean, it's surprising, but they do. And then the sequences change as the reference sequence evolves and as we learn, you know, what is normal and what is abnormal. So these are constantly evolving. So really, you need that. You need some sort of versioned, coded terminology so that you might know what you were looking at when you were looking at it. And so in this instance, we chose 3 different ways to represent gene. And then alterations, we actually, again, went with the NCI thesaurus, and we also just used the HGVS syntax straight. So putting that all together, we had to do a mapping procedure. So we've got a bunch of local codes in the Vanderbilt system, and I'm sure this is the case in many systems. We had to map these local codes more or less by hand to the appropriate gene, alteration, and so forth, and then put this all into a FHIR format. So this is just a snippet of what that looks like, and this is in JSON notation, and I find this much cleaner than that XML example I showed you earlier with the estrogen receptor. I'm sort of a coder. I'm not going to say I'm really a coder, but you know, I think that coders and implementers do find this preferable by far. And I think you can see pretty easily the human readability here. You know, what you're looking at here is EGFR. That's the syntax for the alteration observed using the HGVS nomenclature. That would be what you display at the bottom there for a clinician's consumption. And again, that's what you get from that FHIR code. Okay, so basically what I showed you just now achieves 3 of the 5 aims, I think, that this patient and their oncologist had. So we can learn more about the gene, we can learn more about that mutation in lung cancer, and more about how patients are treated. We are working on the other 2 questions, and I'll just preview real quick here. This is all automated, so we're basically looking at survival by disease, by gene mutation. And it's actually, we were surprised that compared to the whole, like not too many one-off gene mutations seem to impact survival that much. But in lung cancer, EGFR is clearly associated with improved survival. And in melanoma, GNAQ is clearly associated with inferior survival. And I put Oliver Sacks here to remind us all that he recently passed away from ocular melanoma, which is enriched for GNAQ. So we suspect that this may actually not be a genetic effect, but really just a marker for a more aggressive type of melanoma. But that's the kind of thing that might bear further investigation. So what about next generation sequencing though, right? I just mentioned those gene panels, 100 genes, 200 genes. Well, so this is going to be our challenge. So here we've taken real data from Vanderbilt from our next generation. You know, increasingly we're doing these large gene panels, and changed it up a little, hashed it a little bit so you can't re-identify the patient. But this is a real patient who has, I think, 13 different observed genetic alterations, which are variably considered actionable or potentially variants of unknown significance. And I think you'll agree with me that this is not the best way to represent such data. However, we're not sure what is the best way to represent such data. I mean, you can try a bubble plot, but you still have a really crowded field. You can suppress everything that's negative, but then you might lose a lot of information from the rest of your population. So we're still kind of puzzling through next steps here, which is how do we start to present to a clinician and certainly to a patient I would never show this to a patient, I think. You know, Circo's plots are pretty, but I don't think that those are particularly informative either. So we're still working on how to get to the next step here with the more complicated next-gen sequencing data. So in conclusion, I talked about two kind of projects that I've been involved with. COTPS, I think we are producing a way to realize seamless sharing of oncology-specific treatment and survivorship data, so achieving one of those grand challenges of the National Academy of Engineering. And the Smart Precision Cancer Medicine app provides just-in-time information at the point of care and can theoretically be extended how you might want to or reused. Both of these are freely available. You can get Smart Precision Cancer Medicine on GitHub. You can get the COTPS implementation guide at the HL7 site. It would be great if any of you thought you might want to try implementing one or both of these, and you should certainly contact me if you need more information. So I didn't do this alone, obviously. So I have two acknowledgement slides. These are the folks that have worked on the COTPS, and in particular, I want to recognize Ed Ambinder, who's the chair of our Data Standards and Interoperability Task Force, and the folks at ASCO who have worked a lot tirelessly on this effort, and also the HL7 Structured Documents Work Group for being so supportive. These are the folks involved in Smart PCM, and everybody with an asterisk next to their name are people who have actually done programming of the app. And without the HL7 Clinical Genomics Work Group and the Fire Management Group, I don't think we would have gotten to where we are, so definitely want to acknowledge them as well. That's all I got.
Questions?
Are you aware of any like a well-defined process for the standard development? You know, like if you develop software or waterfall model, you know, whatever, you know, different models. I'm
Yeah.
just wondering because I see so many people develop different standards, not just for clinical, but also like in biology.
Yeah.
Everybody have their own ways of doing things, and in the end, you know, things might not be what they want.
So the model that we used was called Greenfields, I guess, or Brownfields, something derogatory. But you know, basically, we built it, we showed it to HL7, they liked it, and then we brought it into the HL7 process. So you know, we got to a certain point with defining the Smart on Fire genomics extension, and then you know, we knew that if we were just going to build it ourselves, it was never going to go anywhere. So we basically pushed to get it included into the ballot version of Fire, and are now working pretty closely with HL7 and also the Global Alliance for Genomic Health and others. I mean, the problem is that new organizations keep cropping up. There's now the Actionable Genome Consortium. There's another one that I just learned about that I'm blanking on the name. So there is an ongoing issue, and that's part of why we have the data standards summits as well. You know, get everybody in a room, get the people who are actually doing this work talking, make sure that we're not starting to diverge too much. But it's an ongoing challenge. Yeah. Yeah.
So for those human plan summarization template defined by ASCO,
Mm-hmm.
what are the reactions of those EHR vendors? Are they embracing or how?
So turns out that the vendor's not enough. You have to have a willing site as well, right? So there's at least one. I think it's UNC with Epic has basically implemented the templates, but they're not auto-populating them. So it's, you know, the problem is, you know, they are auto, you know, some simple stuff like demographics, they're auto-populating, but there's so much more in that template that, you know, the issue with the paper-based one is that nobody was filling it out. I mean, it's just so time-consuming to sit there and write it. And so we hope that the vendors will embrace auto-population, because that's really, I mean, if they don't do that, you know, we're really just back to, then you've got to convince your clinicians or somebody to spend the time to actually enter that data. So that's what we're currently trying to push.
So do they have to go through the EHR vendors, or it could be a third-party company actually they have to?
Well, the government, there's not going to be a meaningful use stage 4, right? But there might be something. out there. So, I mean, ASCO does lobby ONC and, you know, stays involved with policy. And certainly if there was a government regulation like you must use this treatment plan and summary, it's more likely that it would happen. But short of that, we're trying to talk to vendors and payers, because I think payers, you know, are probably perhaps the way into vendors more than anybody, because they know that their patients move around all the time. They're going to all these different clinics. You know, they're moving from one city to another. So, you know, we're talking to payers as well. Yeah. Right, and again, some of them are doing their own things, and so we, you know, again, it's an issue of, you know, making sure everybody's at consensus for what standard they want to be using. Yeah.
All right. There are no more questions. Are there no more questions? Okay. Thank you, Dr. Warner.
All right. Thank you.
Jeremy, excellent talk.
Thank you.
As always, I will see you at dinner today.
Okay.
So I
that'd be
will
awesome.
ask my question about updating all these knowledge bases.
All right. Yeah. Sounds good. All right. See you later.
Right, yeah.